Mr. Chairman, dear colleagues, thank you very much. If you want to start up a program for left atrial appendage closure, you definitely need to get the relevant patients referred to you, and I think it's very logical to look towards the neurology clinics because they have a lot of patients which are suitable for LAA closure and which really can benefit from this procedure. So I'm an interventional cardiologist working in Denmark, working here in Aarhus, which is the second biggest town in Denmark. And during the years, we have established a very close collaboration with our neurologist in Aarhus. This is the Neurology clinic in Aarhus, and it is led by Professor Grete Andersen, which is also in the audience right now, and she has been extremely active also in recruiting patients into different clinical trials where both neurologists and cardiologists take part. So you have to realize that several heart disorders and heart conditions may severely impact the brain because the heart can be the source for embolic stroke. And I think in many cases of cryptogenic stroke, the underlying mechanism might be paradoxical embolism through a PFO. And in Aarhus, together with Professor Andersen, we have been quite actively randomizing patients, firstly into the PC trial. We randomized about 40 patients, and later on we randomized into the reduced trial. And this was really the platform where we knew each other and where we started all our communication and collaboration. But of course, of quantitatively much more importance is atrial fibrillation as a cardioembolic source for stroke. And we all know that during atrial fibrillation, we have very poor contractile function of the left atrium, and we can see thrombus formation in the left atrial appendage like this, which is nearly on its way to the brain. In Denmark, we have a national stroke registry, so we know a lot about how many patients we have, also how many patients that suffers from AF. And yearly in Denmark, we have 10,000 stroke patients. And if you look in the age group more than 80 years old, you will find out that 25% of the patients have AF. In the age group 65 to 80, 15%, and below 65 years, 5%. We have also data for how many of those patients are having oral anticoagulation treatment following their strokes. And if you look at the situation 12 months after the stroke, you will find out that almost about 50% of the patients have anticoagulation treatment. And if you go on to the elderly class group here, over than 80 years, it's not more than 30%. So there's a lot of undertreatment here in Denmark as well. This is data from 2003 and 2006. It's probably a little bit better now, but still we are clearly undertreating this disease. And of course, this has to do about all the side effects that you see with both the new oral anticoagulant drugs and also with warfarin. And we've heard about the long-term bleeding risk, the difficulties with renal failure, comorbidities, and so forth. And I think also a lot of patients in Denmark are just put on aspirin treatment because it's so much easier to handle a patient just being on aspirin. But one thing that we really fear is intracerebral bleeding following oral coagulation treatment. And this patient was a 77-year-old man with a history of stroke back in 1995. He had a diagnosis of hypertension at that time, and later on he developed atrial fibrillation. And that, of course, did give rise to start of warfarin therapy. But even though his anticoagulant treatment was well maintained, he was admitted to the neurology clinic with headache, progressive paralysis, and coma, and died with an ENR in the therapeutic level. So that's really what we fear. So we have 10,000 strokes per year in Denmark. 10% of them are hemorrhagic strokes, and 10% of the hemorrhagic stroke can be attributed to oral anticoagulant treatment. And as you know, the mortality in intracerebral bleeding is very high, around 30 to 50%, and even if it's related to oral anticoagulant use, the prognosis may be even worse. The hemorrhages are larger, the cerebellum is often involved, and they have a worse mortality. So we also know about the risk factors for intracerebral bleeding: high age, hypertension, history of cerebrovascular disease, and of course if you have fluctuating ENR values or high ENR values, or if you receive concomitant antiplatelet drugs. And all those parameters are built in to the HASPET score, which I think is very useful. But there are also new things that might add to the risk estimation of each individual patient, and that is the MRI appearance and the possibility of detecting microbleeds. Because microbleeds in the brain, that is dot-like areas on the MR scan, and it's considered to be hemosiderin deposits due to areas of very minor bleeding due to microangiopathy. And if you see them deeply, they might be related to hypertension, and superficially, they might be due to amyloid angiopathy. And if the neurologists detect those changes in the brain, that really means that there is a high risk of intracerebral bleeding. So why not, with all those problems with anticoagulant therapy, think of this mechanical solution of left atrial appendage occlusion? And the patients are there, and the patients are in the neurology clinics. We have in Denmark 30 to 50 survivors from oral anticoagulant treatment-related intracranial bleeding per year. We have 1,200 strokes where it's related to atrial fibrillation, and only about half of them are treated with OAC. So there's plenty of candidates here. Some will be candidates for some of the new oral anticoagulant drugs, but many of them will also be suitable and good candidates for left atrial appendage closure. And I think it's also important then that we as cardiologists can, in several cases, really solve difficult problems for the neurologist and solve complex patients' problem. This is a patient case that we had in our clinic. A 70-year-old male with hypertension, coronary artery disease, type 2 diabetes, chronic AF, chronic renal failure, in dialysis, and treated with both warfarin and aspirin. He was admitted to the neurology department in February 2010 with an intracerebral bleeding, and again, the ENR was quite near to the therapeutic interval. He recovered that intracerebral bleeding, and of course the neurologist stopped the warfarin treatment, and he was continued on aspirin due to his vascular disease in the coronaries. But only 6 months later, he was then admitted with stroke, had a left-sided facialis paresis and a left hemiparesis, and recovered from that. But 2 weeks later, readmitted with right-sided facialis paresis and slight aphasia, and recovered. If you look into scoring of this patient, he scores very high on the CHATS-VASc score, a score of 6, meaning an annual stroke risk of 7%, and a HASPET score of 6, meaning a bleeding risk yearly more than 10%. He was closed with a 24mm ACP device back in January 2011, and until now, he has had no TIA, no strokes, no bleedings after the LAA closure procedure. We have now in Aarhus performed 34 ACP occlusions of the left atrial appendage during the past 3 years. Nearly all of those patients have been patients with AF and a contraindication to anticoagulant treatment, and many of those with a previous severe bleeding episodes. Many of those also with a previous intracerebral bleeding episode. And half of the patients was referred from our neurologist and the other half from cardiologists. And the mean CHA2DS2-VASc score in this group was 4.7 and the HAS-BAT score 3.7. We experienced only one peri-procedure complication. That was our second case, embolization, that it embolized to the abdominal aorta, and we could snare it there and put in a new device, and there was no sequelae. And we have also 2 months after the procedure seen a case with thrombus formation on the disc of the device. But it did regress and was gone away after readmittance of warfarin treatment for a period. So we have to realize that it is in fact the neurologist and not the cardiologist that are faced with the severe complications of AF. The patients with stroke or the patients with intracerebral bleedings, they are not in the cardiology department but at the neurology clinic. And I think those who survive an intracranial hemorrhage are obvious and very good candidates to benefit from left atrial appendage occlusion. And I think also that the neurologist has the follow-up of the patient after stroke, and they should really pick up all of those patients that are not receiving relevant therapy and also pick out those that would be suitable for left atrial appendage closure. But many neurologists are not completely aware about this new possibility of occluding the left atrial appendage, or some of them consider it still an experimental procedure with a high risk. But I mean, the peri-procedure risk is definitely not 7% any longer, as we saw in the initial PROTECT AF trial. We know in the European Prospective AC observational study, the risk with the ACP device is down to 2.9%, and it's also considerably lower in the new Watchman Prevail trial that we just heard about. So I think we have learned a lot since the PROTECT AF trial, and also the LAAO devices are now technologically improved compared to the Watchman device. So I think it's very important to establish collaboration with the Neurology Society and your neurology colleagues to teach them about this new beneficial therapy for a lot of patients, and also to be part of heart-brain symposia and meetings on new oral anticoagulant drugs, just to expand the knowledge of this therapy that can be effective to prevent stroke in AF. And what really started the good collaboration between cardiologists and neurologists in Aarhus was the commitment to clinical trials. In our case, it was the PFO trials, but I think we really also need clinical trials within the area of left atrial appendage occlusion, and it would be really nice if we could have more clinical trials in Europe as well with the ACP device, and obviously in the patients in the patient population that do not tolerate oral anticoagulant drugs. And another way to collaborate would be to have registries, and I think it could be very nice if we could register all our ACP cases in an international registry to collect and learn from this procedure, and learn what are people doing after the procedure. Are they continuing aspirin for 6 months or lifelong? And it could answer a lot of questions right now where we only have one randomized trial. So let's really register all our implantations. I think that's also essential. So why don't you really go back and establish good collaboration between neurologists and cardiologists? I think that's very essential. Thank you for your attention.